audience today. This is our next segment in our series we're calling Wrangling Parenthood, presented by Chisholm Trail Pediatrics. I'm your host, Shane Littleton, CEO of Chisholm Trail Pediatrics. I'm joined today by our expert, Dr. Kevin Taheri, local ear, nose, and throat doctor who's going to be talking to us about issues and problems that he sees in his specifically pediatric patients. Today, we're going to be touching on issues like tongue ties, ear tubes, tonsils and adenoids, pediatric sleep apnea, and those pesky Central Texas allergies. Dr. Taheri has been one of the pediatric ENTs that we refer to the most here at Chisholm Trail Pediatrics due to his success rate from his pediatric patients. I can attest to his skill personally. He placed ear tubes in my daughter, and he also took out her tonsils and adenoids. And she has not had an ear infection since she put those in. And she can actually breathe at night without snoring since the adenoids and tonsils are taken out. So after both those surgeries, just the respective problems were corrected pretty much immediately. Welcome, Dr. Taheri. Why don't you tell us a little bit about yourself and what makes you an expert as an ENT?
Thanks, Shane. Thanks for having me. Greatly appreciated. I am a board-certified ear, nose, and throat surgeon, otherwise known as otolaryngologist, which is a horrible name for our specialty, but that is. I attended college at UT here in Texas, went to med school at UT Houston, and then went back to Louisiana, which I grew up for my ENT training residency. I've been here for 7 years now, taking care of both adult and a lot of pediatric patients.
Excellent. All right. Hook 'em horns. So I know here in primary care, this is usually where the patients start, and they come and see us with ear infection 1 and 2, right? And we decide if it's 3 or 4, whether they're getting a certain time period, it's time to send them on to guys like you. What happens next? Like, what happens when the provider refers to the ENT for ear infections? Where do you take over?
Yeah, so we like to look primarily when we're at that 3rd or 4th ear infection. 4 is the magic number, but sometimes things get really severe after 3. It hasn't cleared up, so we get the referral.
Sure.
We start by taking a thorough look. We trust you guys. We get the history. We get the physical exam. But then the next step is to actually look into the ears and see, does it still look bad? Is there still fluid behind the eardrum? Is there still infection? What is going on? And that helps guide the recommendations. Typically, after infection number 4, if it's 4 episodes of recurrent ear infections, the recommendation is for ear tube placement. We always take a look to see what is going on. Does everything match up? Where are they in their antibiotic course or cycle? Do things look like they're improving, or are things even worsening despite being on the antibiotics? So first, take a thorough history, thorough exam. Take a look at the picture, get a family history. A lot of times these things do, unfortunately, run in families.
Okay.
You'll often see one parent or another who had ear infections growing up.
Interesting.
Maybe even had tubes placed. Usually, yes, you can point to either mom or dad as the culprit. And then we talk about what it means to go through ear tube surgery. So you've been familiar with it, but it's very common, and that's what really we like to tell the parents. It's the most common surgery for kids in the United States. So there's just a certain percent, not just like any surgery on kids. It's the most common one is the tube placement. So I think that helps people realize that a lot of people are going through the same issue. It's very common. You're not the oddball. Certainly, I gained a new appreciation for ear infections when I became a parent.
Oh, right,
Yeah. I've got a 7 and a 5-year-old, and they didn't have the level of infections for tube placement. But man, when you're up all night with them, they're crying.
Sleep, they can't put their head back, they can't get comfortable. Oh, we've been there.
They're sitting there on top of you, and either you're not sleeping or your partner's not sleeping.
Right.
Kid's not sleeping. You're just like, oh my gosh, anything to help the cycle. And then sometimes they do have to do multiple rounds of antibiotics, which is hard. You go through 10 days. It doesn't clear up. You got to do another 10 days. And that's the treatment algorithm, but it just gained a whole new appreciation to say, okay, this is what people are going through. You kind of know it in your mind, but then to actually go through that a couple times with your own kids, you're like, okay, I know this. So we'll take a look in the ears and then start determining what the plan of action is. Most of the time, they've met the criteria, and that's the recommendation, which is for tube placement. Sometimes they're not. We'll bring them back for a repeat exam, or we will set a follow-up at some date to discuss further, see where we need to go. But if we are proceeding with tubes, so we'll like to say, okay, this is what we're going to do next. Talk about the procedure. It's a in and out surgery. Typically it takes about 10 to 15 minutes. It's
I was surprised how quickly you did it. I really was. Like, we dropped her off, and then you were out there before I could even pull up my laptop, I feel like. So, yeah.
Yeah, I like to joke, like, parents, you don't get that much of a break.
Yeah.
You know, they go under, but really it's pretty quick. It's pretty simple. We do it in the operating room. Sometimes there's a misconception. Maybe we do it in the office. The reason for that primarily is safety. That's the safest place. We have the board certified, just like I'm board certified in ENT, the anesthesiologist and the nurse anesthetist. We're a team in there. So they take care of your little one while we're in there. They do all the monitoring for all of that stuff. They let me just focus on the ear portion of the surgery. So I tell all my parents, it's a day surgery. Come in that morning. You leave later that day. Surgery itself takes about 10 to 15 minutes. The anesthesia time is really even less than 10 minutes. It's pretty quick. They just use a mask anesthesia. The reason for that, it's really quick. They inhale the gas. They go to sleep. They turn the gas off. They wake back up. Allows us to sit still. We need stillness. They can't be moving around while we're inside the ear. So we make a small incision in the eardrum, suction out any fluid or infection that's there. Another common misconception, we don't need the infection to resolve. In fact, that's a lot of times, that's why we're doing it. We don't need to wait for this to clear up. We need to just get them to surgery to help with it. The tube goes into the eardrum, and then we use some antibiotic ear drops afterwards for about 5 days.
All right. And I know, at least for my daughter Ray, it cleared up her ear infections almost immediately and pretty permanently. Is that usually what you see?
Yeah, so the reason for that, it's called, it's hard because it's another tube. So we're talking about putting tubes in the ears, but the reason why kids get ear infections is because of their eustachian tube. So the eustachian tube is the tube that connects the ear to the back of the nose. It's the tube that you clear when you're on a flight, you're descending, there's pressure. And kids are born with a horizontal position of the eustachian tube. And as their skulls get bigger, it becomes a more vertical position. That's why adults don't get a lot of ear infections. We still see them in the clinic. You know, you might get a bad cold, but it doesn't always back up into the ears. I get a little fullness, but not, okay, I don't have to get put on antibiotics for this infection. And so that's why there's a certain percentage of kids who just cannot clear their ears. So that's why you're trying an antibiotic, they get a cold, they're in daycare, and it always backs up into the ears. Yep. And then they're in your clinic. Yep. And then you try the treatment algorithm, the amoxicillin. Amoxicillin doesn't work. You bring them back augmented.
They get worse and worse as you go down the line. You know?
And there's the Ceftonir tube. It's a Hail Mary. That can help. Usually, sometimes it doesn't at that point. That's when you come to see me. So there's a certain percentage of kids, they can't clear their ears. So then the tube that we put in there is acting like a eustachian tube. It ventilates behind the eardrum, what we call the middle ear. Okay. And so it allows a communication. So like a lot of questions we'll get, oh, can my kid fly with an ear tube? Actually, yes, it's like the best. They don't even have to pop their ears. Their ears are ventilated already. Interesting. All right. So then as they grow bigger, their skulls grow. And so the eustachian tube grows at the same time. And so we're buying time for their natural eustachian tube to do.
Gotcha. And I know that the recovery time is very little and there's almost no side effects to the tubes. But what would you say to a parent who is a first child and they're apprehensive about sending their child into surgery?
Yeah, I say, we've done this literally thousands of times. Literally, probably about 500 sets of tubes a year. And I've never had a problem with the anesthesia. The youngest I've done is about 4 months. That's very, very, very rare. Wow. Typically, they're more in that 9 to 1 year age, and that's what I always think. Well, we've even done a 4-month-old, and they've done fantastically. Stuff that they've really been doing since the 60s. So the technology has improved, the anesthesia has improved. They're experts in their field. I'm an expert in my field. Right. You'll be taken care of.
And I know that they can fall out, right? How many patients have you had to bring back to replace them?
Yeah. So the tubes, I also go through, they're not permanent. They have a shelf life. They tend to stay in the eardrum about a year or so. Okay. Sometimes they can take longer. That's really not a big deal because it's more time for their skulls to get bigger. Sometimes they fall out too soon and we have to go back for a second set of tubes.
Gotcha.
I'd say ballpark, there's about 10% of kids that need a second set of tubes. Okay. This is all comers. Either they fall up too soon or their ears just don't quite mature the way they should. And so it's been, a year and a half, 2 years. They are that older child. They're now about 3 years old, and they need a second set of tubes because they've fallen out and they start to get fluid again, or they start to get infection.
Well, I can tell with my daughter, they're both out at this point because it was a couple of years ago, but she still has not had an ear infection since. So
she's matured. Her skull's gotten bigger. She should be good. We never say never.
Right.
As doctors, we always hedge, but everything is good.
Excellent. Well, I know we each had a great experience. All right, moving on to some other procedures you do. I know you work with the tonsils and the adenoids, but talk to me a little bit about how that's related to pediatric sleep apnea. Specifically, what is pediatric sleep apnea?
Yeah, so apnea means pauses in the breathing. And so pediatric sleep apnea, pauses in the breathing when you're a child. And so these are things that you at home, you may see. So things include snoring. Sometimes you can actually see the apnea. Parents will come in with, I welcome the recordings. Technology's great.
Oh, they film the
style. Yeah. I like that because that's what we want to see. Typically, even 10 years ago, we didn't have the iPhone to film or record, and we would have to sort of imitate these noises. and I'm horrible, but I'm going to try to imitate the noise. But it's like they go.
That pause.
Just a pause,
like,
and then
my child's not breathing. What's going on?
It's a big gasp. And so we know from our studies that kids are not supposed to be snoring. So all comers, when you hear snoring, it usually means something that's going on. We allow a certain amount of snoring, but then we look back there to see what's going on. And so sleep apnea means like there's actual pauses in the breathing or decreases in oxygen. Most people are familiar with the adult version. And so from an adult version, we usually diagnose that with a sleep study. And so that's where you have to go into the lab or take home some equipment to where that actually measures the oxygen and sees if there's pauses in the breathing. The pediatric recommendation is slightly different. And so people get a little bit confused about that. We don't order that many sleep studies on kids. And the reason for that is it's not the recommendation. First of all, it's very hard to do. As you can imagine, you're going into a lab and you're connecting. The kids ones, they don't allow you to do at home. So you have to go into the lab.
Well, if we can't put the kids to sleep at home, how are we supposed to be able to put the kids to sleep in a lab connected to wires?
Exactly. Kids at home, they might sleep in the bed. They might start in the bed, come into your bed. Sometimes they never sleep at all.
My kid just wants to stay up all night.
My son was up till like 10 p.m. I don't know. He couldn't sleep the other night. So, what happens when you go into the lab setting and it's a foreign setting, they can't go to sleep. Then you're there, you're at night, maybe they get 2, 3, 4 hours of readings, and usually that can be enough, but it's not the primary recommendation. The recommendation is to see an ENT specialist to look in the back of their throat. Okay. And so if the anatomy matches the symptoms, meaning we hear that there's snoring, there's mouth breathing, and you look in the back of the throat and you see enlarged tonsils, that is what's causing the issue until proven otherwise. So the current recommendation from our ENT Academy is not to order a sleep study. Actually, the first line treatment in pediatric sleep apnea, so this differs from adult sleep apnea, is to take out the tonsils and adenoids if they're enlarged. And so you say, okay, well, what does that mean, or what does that entail? And so the tonsils, most everyone has heard about the tonsils. Right. They're the tissue in the back of the throat. You can look back there, and kids, flashlight works great. And a lot of times that's what I'll do. I'll actually get the parents, have you looked back there? And so that helps me show them what I'm looking at. So, and I just had this consult this afternoon. I said, have you looked back there, Mom? She said, yeah, I know. And so you can see, so either the tonsils, they're on the sides of the throat, on the inside, and we grade them on a scale of 1 to 4. So 1 and 2, that's within normal size. 3 and 4 are the enlarged size. 4 is the largest. Except there's one more. When I didn't come up with this, but they call them kissing tonsils. They're actually they're kissing each other.
Oh, I got you.
They're actually kissing
each other.
Yeah.
Interesting.
Those are actually the biggest, but usually we see them on a scale of 1 to 4. And you look back there and you see that size 3. Typically we see size 4 when you notice the snoring, the mouth breathing, and the gasping. That's the recommendation. The other thing that we talk about are the adenoids. And so this is where it gets confusing because you can't actually see the adenoids.
Right.
They're actually all the way in the back of the nose. If I took where you would get a COVID swab from. Now we know. That's actually in the nasopharynx,
back
all the way in the back of the nose.
Nasopharyngeal swabs, those are fun.
So we don't typically look at those. They are the same type of tissue as the tonsils. If the tonsils are enlarged, then the adenoids are enlarged too. So the recommendation is to take both out at the same time. So I'll start by, again, taking a history. Okay, is there snoring? Yes. Is there mouth breathing? Yes. Kids really aren't supposed to be mouth breathers. And then I watch the child too. A lot of times, we're talking as a parent. My eyes always, to see what is that kid doing. And if you can see they're breathing heavy, their mouth is open, and you get the video from mom or dad, and you put it all together, and you look back there, and I tell them, okay, this is why. This is a recommendation. So we know that sleep apnea. I'm going to bring it back around. When you go to get a sleep study as an adult, there's a certain amount of pauses that is normal. In kids, no pauses are considered normal. Okay. So we don't typically get a sleep study, but even if there's 1 an hour, that's the recommendation. So it's hard to get a sleep study. The first line treatment is to remove the tonsils and adenoids.
Just to go for it.
Yeah. And typically those kids that we'll see is usually around the 3 to 5 year age. Yep. So they tend to be a little bit younger. It tends to have gone really by 3 years old. They've grown into their tonsils. So sometimes if they are younger, we will give a little time. Sure, we don't want to take out everyone's tonsils that come in. We want to give a little time to see, do they grow into them? Does this go away? But if it's been going on for 6 months, they're 4, they're 5 years old, it's time.
Yeah. Well, I know that it did wonders for Ray, our daughter. And I remember when you came out of the operating room, you were like, Shane, they were big. And we definitely made the right call. And she's been sleeping better. She still gets scared. But she's breathing.
Yes.
At night.
And the reason why that's so important, we know from studies that the snoring and the apnea interferes with their sleep restoration. So everyone knows it from adult sleep apnea. Just think of it as a little bit of a smaller version here for kids. So they're not going to get the cardiovascular stuff, but it's going to affect their cognition. It's going to affect their memory. Actually, the landmark study was done in the 80s in New Orleans, so it was drilled into us in my training. Like this originated here about school performance.
Really?
Yeah, in 6 and 7 and 8 year olds. They randomized them, half got their tonsils and adenoids out, half they waited a year and got their tonsils and adenoids out. They did better in the previous year.
Interesting. Is that because they're sleeping better and they have better cognition because they're sleeping better, getting more oxygen at night?
Better rest, which serves for better memory.
Yeah.
Serves for better learning. So, it's never a one-to-one. You don't say you do this and immediately improves outcomes. But we also know that it can help with things like attention deficit, ADD, and ADHD, hyperactivity. Because if they're not getting the full sleep, it doesn't cure. Nothing cures, but it helps. What I say, it helps the child to be the best version of themselves.
Right.
So if they have something else going on that we can improve, that we can help with, we're happy to. From a surgery perspective, now the tonsils and adenoid surgery is a little bit different.
Yeah, big time.
So it is about a 30-minute surgery, still not long from a surgery perspective. They do go fully under from an anesthesia perspective. It's not just the mask anesthesia. They actually do put a breathing tube down. They start with the mask. They start an IV. The IV started after they go to sleep. So they don't have to fill it. We don't have to start it beforehand, as you can imagine.
That
we don't want to be starting a lot of IVs on kids. Yeah, that doesn't work. But then the surgery takes about 30 minutes. The recovery is a bit longer. So it is something that we have to plan for as far as a recovery perspective. In kids, it's about a 1 week. It's about a 1 week soft and liquid diet. How was y'all's recovery from that perspective?
It wasn't great. It was about the full 10 days. But like you said, we saw you on day 7. You said it's just going to fall off. And about after day 10, she was back to normal. But it was typical like sore throat stuff, just a little grumpy.
It was manageable.
But it was definitely manageable. And then once day 10 happened, she was back to normal, and then she was breathing. And she was breathing while she was recovering.
Yeah.
And it was very comforting for us to watch her sleep, and she's way more comfortable instead of just gasping for air all night.
And I've heard that a lot before, not just from you guys, especially the kids that sleep in the bed. So parents are used to a certain sound, and of course they'll sleep in the bed afterwards. They're just recovered from surgery, so it's appropriate to watch them
for a week.
And they'll have to say, like, "Man, I had to wake up a couple of times to check on them in the middle of the night because it was so immediate,
so quiet."
I'm used to this white noise going on.
Yeah.
But you were alluding to the scabs. Yes, that's what. So the reason for the prolonged recovery, the throat heals from the inside out. And so you get these scabs in the back of the throat, and they just have to fall off. It takes about 7 to 10 days. Usually by 7, we can get you eating a more full diet. We do put them on some pain medicine. It's not for a prolonged time, but it's just to make them comfortable so that they can eat. We do not put them on antibiotics. So that actually was an old recommendation.
Okay.
They changed that about 10, 12 years ago. They used to put all these kids on antibiotics after they thought it helped with healing. Then they came out with another study. We're always learning that we don't have to. So that's actually really great. One less antibiotic that you have to do, and one less liquid that you have to put in during the recovery.
One less thing you have to shove into their mouth and make sure that they take. No, but she did fine with it. I will tell you, the worst thing about the recovery is the breath. My goodness, my poor little girl, her breath smells so awful, and she wants to be right here. Right? She's not feeling great. She wants to be right here with you at all times. So we're just like, okay, baby.
And I remember I forgot to warn a parent once. You go through all these things. You kind of have your mental checklist in ahead of the things to go through and warn people about. And she said, "Man, it's the exact same thing."
It's like rotting flesh.
Was that okay? I said, "Oh man, I'm sorry, I forgot to tell you." She said, I figured it was fine. I looked it up, and that was good.
Right. Well, any other issues? I know those are the big ones. You want to touch on tongue ties real quickly?
One more thing with the tonsils,
Great,
and then we'll move on. So that's the young kids. That's the kids that we see at about 3 to 5 years. And so that actually is the number one reason why we remove the tonsils and adenoids at this point. The number 2 is what people have traditionally thought is the chronic strep infections. And so, again, we see the referrals, multiple episodes per year or every year, 3-4 infections a year, antibiotic therapy. And those tend to be the older kids. The reason for that, accumulate the number of infections. They've been in school. That tends to be our, 6 and above, 7, 8, 9, even sometimes even to the teenage years.
Really?
Yeah. A lot of times for them, it'll be, okay, maybe we thought about doing it when we were younger, but it just didn't happen for whatever reason. And so now it's, come on.
I will tell you, get it done young. It's a little bit easier when they're younger, and then it's over with and it's done, and there's less of a chance of being strep throat when they're older.
So the chronic strep infections, that's definitely an older thing. But again, the strep and the bacteria live inside the tonsils. They used to think, again, an older thought that you needed your tonsils and adenoids for immunity, like they actually served an immune function to protect you. Now we know that's actually an older way of thought. So removing them, they actually hold on to the bacteria. And it's a little gross, but when you remove them, you see all these like nice little white spots that hide behind them, and it's gratifying. It's gratifying because they just needed to come out too. Right. So that's the number 2 reason why we take out the tonsils in a pediatric age too. You were talking about tongue ties.
Tongue ties. I mean, the biggest
what have
thing.
Seen?
So what we see is the poor babies not being able to latch and not getting the nutrition that they need. Sometimes it's very apparent, like the baby can't let their tongue out of the mouth. But sometimes it's not as apparent, and we're trying to figure out why these babies can't latch on the breast or even on a nipple or anything like that for a bottle. So then we talk to you, and it's a pretty routine surgery.
Yeah.
Isn't it still outpatient?
Still, I'll walk you through it.
Okay.
I promise. So I became interested in tongue ties when my son was born. So he was 7, and he got diagnosed with a tongue tie. And we actually did not get, at that time, much training on tongue ties in our residency. We were more focused on kind of complex pediatric issues. Yeah. So sometimes you don't see the bread and butter. But so I was able to do, of course, when it's in your own child, you do a deep dive. I read like all the And a lot of literature is from the pediatric dentistry. So I think they were a little bit ahead of the curve on here. So I read all the journal articles, right, to learn about it. And so, and since then, as we have transitioned to more breastfeeding, and there's more lactation consultants, I don't think the incidence of the tongue tie has gone up, but the recognition has gone up along more. And so now we'll see a lot of referrals. And so there's a couple different types of tongue ties. So we'll get the referral either from you guys or sometimes even straight from the hospital. So
the hospital is right there. Like, this child's going to need it.
That they'll need, that they'll
Day
need
3, they know.
Yeah, that they'll know. They'll take a look. And so sometimes it's really apparent. And so the tongue tie, what it really refers to from an anatomical point of view is the frenulum. The frenulum is that piece of tissue that attaches the tongue to the floor of mouth. And so sometimes you can see it's that classic, that kid just cannot elevate the tongue. And so when you can't elevate the tongue, it can lead to painful latching or slow feeding. And so either mom will notice it, especially if they've had more than one child, they'll notice, this doesn't feel right. This wasn't the same as my previous child. Something's off. Or the help from our lactation consultants and our pediatricians to identify it is so helpful. And then we'll get the referral. And so again, starts by taking a look and first taking a history. What is going on with the kid? Are there any other abnormalities? Anything else that could contribute to it? What is the mom seeing? Is it slow feeding? Is it no feeding? Are they doing formula supplementation? Is there weight loss that's associated with this? Or and of course, each thing puts a little bit more in your mind of like, oh, how important is this? Because when you look there, sometimes it's very, very obvious. Those are the no-brainers. You look there, the tongue is attaching really right behind the teeth. It cannot extrude, cannot elevate the tongue. And then the procedure is actually pretty simple. It's actually an office procedure. Right there, especially for the simple ones. So we use a pair of sterile scissors to clip the tongue. I get in there with my fingers. I've got my headlight. And then right there, that area does not have nerve endings.
Oh, really?
They actually typically don't even really cry that much. They hate my fingers in the mouth.
Well, of course,
The glove fingers taste like nitrile gloves. But then, I sue them immediately afterwards, and we clip that piece of tissue. And then they can feed immediately.
Yeah, doesn't it help with the healing process actually?
Yes, because there's more movement, so it helps prevent a reattachment of the tongue. So some are very obvious. Those are the more severe tongue tie, class 3, class 4. Some are not as obvious. Maybe they're further back, what we call a posterior tongue tie. That one's a little bit more involved. If they're caught early, we can still do something in the office. If it's later, much later, 6 months, then we do go to the operating room for a pretty simple outpatient procedure. The reason for that, if they're in the office, they can't move, it's pretty easy. You just do it. But that's where, if it's further back, there's a little bit more of controversy of okay, will this help or will this not help? That's where the history really comes in to see what is mom doing? What is our goal? Is it to try to breastfeed, or if they're losing weight, and just say, well, we've got to try. We've got to try everything.
We're going to send them to you anyway and be like, we need to get
to try to ASAP. And we see those referrals really within a day or two because, again, we don't want to. It doesn't do any good to wait a month. We want to get parents in. I know they're anxious. I was anxious when we had my son to read about it to see what we need to do, and it doesn't do good to put it off. The earlier the better. But it is a simple procedure. It's done in the office. I walk every parent through. I like to say, you can stay. Mom can stay. Dad can stay. One can leave. One can watch. Yeah, there's no right or wrong. So some people have an appetite for it. Some people, it's very quick. They're like, oh, really? That was it? That was it. I got called to the hospital actually pretty recently, last week, because they had admitted a child for falling off the weight curve. So they were doing all the supplementation with formula, and they noticed the tongue tie. And so, I brought my sterile scissors. They were like, yeah, the parents, of course, on board. We did it. Oh, really? That's it. That's it. So we know that it helps, and so we're trying everything that we can do to help with that.
Well, I know you guys are really good about getting people in, especially babies, like you said, to get them in very quickly. And you had Started your own practice.
Yeah.
Why don't you talk to us about Breathe ENT?
Oh, so this has been a labor of love. So I've been in a group practice for 6 out of the 7 years. I made the decision to go out on my own. It was a big decision, but ultimately I think it will be the most rewarding thing that we do. And so opened up a brand new clinic. I'm by myself right now. We're in Cedar Park, Texas, but we see referrals obviously from Georgetown, Leander, Central Austin, even all the way up to Temple and Killeen, who come down to see us in the clinic. And so we see primarily ENT through all ages. So I do, obviously, pediatric is a big focus of mine. It's a big passion of mine, but from newborn.
All right.
From newborn all the way to geriatric. But we see them for all sorts of conditions, from everything from allergy to the most common stuff that we went through today.
Excellent, excellent. Well, that's all the time we have for today. I do encourage all of our viewers to check out the link. We have linked his website, Breathe ENT, in the details of the video you're watching today. Thank you to Chisholm Trail Pediatrics and our producer, Emily Littleton. Thank you to Dr. Kevin Taheri for being here with us today and definitely informing our audience about ENT issues and pediatric patients. If you guys did enjoy what you saw today, give us a thumbs up, support the channel a little bit, support our podcast. If you would like to schedule an appointment for your children, come in and see one of our wonderful providers, or to see Dr. Kevin Taheri yourself, give either one of our offices a call. Also be sure to check out the Facebook pages and the websites that you'll find. There'll also be a link to our website for Chisholm Trail Pediatrics. All that information will be available in the details of the show. Until next time, please stay safe, and I hope everybody has a great summer.
Yes.
Thank you very much.
Thank you, Shane.